Thank you, Sheila. And I will thank you everyone for attending today. And I'm happy to be very happy to be moderating this session. A topic very close to my heart and close to the work that I'm doing with OICR. I'm coming to you today from Halifax, which is the Mi'kmaqi, the ancestral and traditional lands of the Mi'kmaq people. So I want to acknowledge that first off. Okay, a few definitions here as we get going with the conversation, just so we're all speaking the same language. So when we talk about patient partner, we're talking with someone with lived experience as a cancer patient, caregiver, or family member. In our case, someone who collaborates with OICR and OICR supported researchers to bring that patient perspective to the Institute and all the things that we do. So whenever we say patient partner, it's always implied that we're also saying caregiver and family member, even though we only ever really say patient partner. But we, of course, embrace caregivers and family members who take on that role when patients can't, or who also have, obviously lived experience of the cancer experience as well. And patient partnership in research is an approach that involves meaningful and active collaboration in governance, priority setting, conducting research, and knowledge translation. So I want to distinguish that from patient participation in research, where they are subjects in the study, or patient engagement in their own healthcare and healthcare decisions, which are also, of course, very important. But what we're talking about today here is when patient partners become a member of or part of the research team and making decisions and directing the research. The OICR PFAC, we call lovingly the PFAC, or Patient and Family Advisory Council, is our external advisory body of currently 8 patient partners who advise OICR about how to roll out patient partnership, how to conduct patient partnership in the organization, and really play really key roles in determining how we roll out patient partnership across the organization. But also those 8 members have taken on a lot of roles within the organization in terms of advice on specific projects or advising themes. And we have 3 incredible patient partners who are on the PFAC here today, Diana, Terry, and Carol. And the OICR patient community is another group of patient partners related to the PFAC, but this is a sort of a pool of volunteers, people who've raised their hand to say, we want to get involved at OICR with patient partnership and research. So we look to this group whenever a request comes through from a research project or a theme or a department who needs a patient partner as part of their work, as part of patient partnership. We go to this group of patient partners to source a partner for them. And this is who's on our PFAC. We're very lucky to have 8 very experienced, knowledgeable, and committed patient partners on our PFAC. Many of these members have been on the council for almost 3 years now, and we've built a really excellent, I think, patient partnership program in about 2.5 years, and we really have these folks to thank. So I want to discuss a few of the benefits of patient partnership. So for researchers, and this is just a short list, a bit of a highlight, partnering with patients can give researchers and other healthcare stakeholders access to insights from the patient experience. So these are insights that are not available to clinicians or researchers without having gone through that experience themselves. And I also think that even as a clinician or a researcher, when you're in that role in a research project, even if you have cancer experience, you're not able to wear 2 hats at the same time. So you really want someone who is dedicated to provide that patient experience insight on a project. Patient partners can also ensure that studies are meaningful and impactful to the people that are ultimately intended to benefit from the research. Patient partnership improves knowledge mobilization by acting as a translator between the researcher and the public. So there is no greater ally or no greater champion or fan of cancer research than patient partners that have been involved. And there's no more receptive audience than other patients that those patient partners have access to. So really getting the results of the research out to the people who really want to read it or see it. Patient partners are great allies and champions of doing that. And then for patient partners, what they get out of the process is being able to influence the direction of the research towards the patient point of view and toward patient interests and priorities. Feeling like they're ensuring the voice of the patient is represented, so being that voice for other patients because they do want to help. And then creating knowledge and expertise themselves that can be leveraged for future projects or is part of their learning journey and their experience. So we have other patient partners on the call today that are going to very ably go through a lot of the opportunities and a lot of ways that patient partners get involved in research. But one that I want to highlight is funding reviews and progress reports here at OICR. So how we've rolled out patient partnership in that area. So since 2021, all applications for funding at OICR have required patient partnership plans. So every single application has to tell us how you're going to partner with patients, when you're going to get them involved, how you're going to find that patient partner, and then every step along the way in the research process, how they're going to involve. And of course, we want to make sure that that's relevant and meaningful. We don't ask; it's not a checkbox opportunity, and it's everyone's very sensitive to that. We want to make sure that everything that's going in the patient partnership plan is no more and no less than should be there. And then patient partners review applications and provide comments, and they also actually sit in the funding review meetings as well. So that's been the case since 2021. Patient partners are part of the review process from the receipt of the applications all the way to the ultimate review meeting that will determine who gets funding. And we are investigating, including patient scores into the final score. Currently, the patient partnership review, or the patient partner reviews and patient partnership as an aspect of applications is included in the overall scores from these scientific reviewers. And then once projects are funded, funded projects will provide progress reports, and those progress reports are also reviewed by patient partners, and they can provide comments to comment on or provide advice on how to execute on the patient partnership plans that were part of the applications as well. And in terms of evaluation, we've modified the peers scale, which is a validated tool that was created at UBC to evaluate patient engagement. And so we've rolled that out to all researchers, all patient partners on projects, and all patient partners on advisory boards and committees in this past fiscal year. And the results from this past year, from 2023, were very good. And of course, we have feedback on how we're going to improve our evaluation process. But so far, the results have been extremely positive from both sides. From the researcher side, feeling like it was meaningful and important, and from patient partners feeling like it was a meaningful experience for them and an impactful experience for them as well. So that was very encouraging to see. Okay, and I'll pass back over to you, Shola, in terms of slides.
Okay.
And now we'll welcome Terry and Diana. So it's my pleasure to introduce Terry Harwish, who is a blood cancer survivor and proponent for a healthcare system that consistently delivers impactful patient-oriented outcomes and experiences. He's the vice chair of our OICR PFAC. He applies his lived experience on a variety of research programs as well at OICR and at other organizations, and he's done so for years. He contributes to patient advisory support to healthcare organizations. He's semi-retired professional engineer and holds degrees in engineering from the University of Toronto and Queen's University. And Diana is also on our PFAC. After an 18-year career as a registered dietitian, Diana's ongoing interest in research led to an MSc Epidemiology and Biostatistics at UWO, which is now Western University. Diana's graduate training allowed her to move into corporate and program level evaluation and decision support roles at UWO, LHSC, London Health Sciences Centre, and St. Joseph's Healthcare London. And Diana is a colon cancer survivor and retiree. She is also a member and past chair of PFAC at OICR, as well as a patient partner with the Adaptive Oncology Program. And I'll pass over to Terry and Diana.
All right. Okay. Thanks a lot for the introduction, Justin, and you brought up a lot of good points. I think I'll probably reiterate some of them, and it's certainly worthwhile to do so. Okay, so my name is Terry Harwish, and I'd really like to thank OICR for the opportunity to participate in this event and share our perspectives. Been a member of PFAC since its inception. I say it's been a real rewarding experience, largely due to the amazing people that support us and guide us and collaborate with us. Not to say it's always been a walk in the park, but such collaborations, I think, have been really worth the effort and are contributing to research that's impactful and relevant in its eventual clinical uptake. And also at the bottom of the slide, I really believe in those words on this slide and cannot stress how important they are as enablers to good patient engagement. So the focus of my following slides is to highlight some of the challenges and opportunities I've observed both as a member of OICR's PFAC and also as a patient advisor with other cancer research organizations. And the slides contain some practical observations and are a bit activity focused, which is really reflective of the engineering in me. Sorry. Anyways, on to the next slide, please. So the next couple of slides are a high-level snapshot of how patient engagement is applied at OICR. And these are examples of program-level patient partner activities and roles that support and elevate the patient voice in clinical research. Justin touched on some of them: participation in PFACs, of course, participation in the governance, and participation in research application funding reviews, research program progress reviews, and participation really across all stages, early to late, of the research study, and also advocacy and promotion. Next slide, please. So here's a deeper look at the research project level, and gives you a sense of where patient engagement can be applied across the various stages of research. And note that each project is unique, as are the eventual mix of patient partner activities selected to support the project. Next slide, please. So what are some of the key challenges to integrating the patient voice in clinical research projects? Well, I guess based on my personal experience, let me preface this by saying these bullets are by no means reflective of every project, and many of them are done extremely well. However, there still remains, some that continue to require maybe a little bit of deeper attention. So one of the first challenges I've highlighted here is the early alignment of research outcomes with perspectives and experiences of those with lived research. And this interaction sometimes does not get the focus it deserves. The patient voice should be introduced early to help shape the research question and to set patient-oriented outcomes that are really relevant and impactful to the patient community. Another challenge is patient partner accrual and trying to find that perfect fit for the researchers and patient partners. And that's pretty tough. Attempting to source and accrue patient partners that have relevant experience and demographics to support the project effectively, while also trying to match the interests and availability of the patient partners. Another challenge is really the effective onboarding for patient partners in terms of reference development. And once patient partner roles are identified, onboarding is needed to address their knowledge gaps. And sometimes what's forgotten is the creation of a living terms of reference document. And I think this is especially important in complex multi-year clinical projects. Another challenge is realizing optimal demographic and sufficient research participant accrual and retention. And this is a common challenge in clinical research, but please note that patient partner advisory can really contribute significantly here to helping with retention and accrual. Now, the challenge is the pivoting on patient partner plans that occur when changes to a research program protocol take place due to a whole host of different factors. And this could have a major impact on the patient partner contribution to the project, if not addressed in a timely manner. For example, revising the patient partner plan accordingly. Another challenge is project progress reporting and fulsome updates. And this is providing a thorough status of patient engagement activities, related to the execution of the patient partner plan. And of course, what this does is enables a path for constructive two-way feedback. And last but not least, in terms of challenges, and this is another tough one, is really measuring the effectiveness of patient engagement on research projects, or what I like to call return on engagement. What sort of tools do we use? And we definitely need more focus here, what measurements to apply. And we need to understand how effective we are, and are we, are meaningful impacts being achieved. Okay, so on to the next slide. Yeah, so opportunities. So in balancing some of the challenges, what are some of the opportunities and practices that could help elevate the patient voice in clinical research? There's some things to keep in mind. First one, a real good one, is the earliest engagement of patient partners in governance and ideation and application and protocol of the research project. And the importance of gathering valuable patient input in the conceptual and design stages of research. And this really helps to identify unmet needs and patient-oriented outcomes that are really important to the patient community. Another opportunity, Justin touched on this as well, is patient partner scoring in research project funding approvals. And participation in this activity is really a recognition of the importance of patients being valued as true partners in research. Another opportunity, timely and constructive feedback between researchers and patient partners. I mean, nobody is fond of reporting, as we're all time restrained, but timely and constructive feedback between parties really supports continuous improvements and co-learning, which is really important for the project. Another opportunity is continued training and mentorship and things like EDI, patient engagement methods, and basic science. These really help to raise the awareness, the knowledge level, and utilization initiatives, or utilization of important initiatives that enable better research. Another opportunity is patient partner participation, knowledge dissemination, and advocacy. Science shouldn't remain in the realm of the few. I think patients really can help to translate complex research in a lay manner to key stakeholders. And patients can also play a real good role in the advocacy and related aspects of the social determinants of health. Another opportunity is building relationships with other cancer patient organizations and sharing best practices. So really leveraging the value of sharing and adopting best practices from others. It makes us all stronger. And last but not least, continue to build on great collaboration, continue to learn, continue to apply, and continue to grow. I think we've come a long way over the past 2.5 years or so, and I'm confident that our positive momentum will continue. It's been so rewarding to have this opportunity to collaborate, learn, and apply with such amazing people like yourselves. So thank you for listening, and I'll turn it back over to you.
Thank you, Terry, and I'll pass it over to Diana.
Thank you. I looked at the topic that we were given and took a slightly different approach. And so let me start by saying, finding patient voices is not a problem. I firmly believe that. I think there are many people who have an interest in cancer research Rather, I think the challenge is to answer questions such as, how can we contribute to the cancer research agenda? And I mean to really think through, what can we do as patients and patient partners? How do we create alignment between patient partners and researchers? Because these are two very different groups who have very different views of the world. And we have a responsibility to figure out, where is the alignment? How do we demonstrate our value to cancer researchers? Patient partners and that concept has been around for a while now and is even been termed mainstream, but there are still many people in cancer research who don't understand what the value is. And how do we raise the bar on patient engagement? Okay, so just to remind everyone, here's the official definition of patient engagement from our very own Canadian Institute for Health Research. Meaningful and active collaboration in governance, priority setting, conducting research, and knowledge translation. And at OICR, our PFAC works closely with the executive team to look at issues around governance, priority setting, and that includes the review of funding applications and so on. Policy setting, which takes into account governance. And in contrast, on a research team, we look at not only governance and priority setting in the context of the research project underway, but also actually conducting the research and knowledge translation. So, an area where we can begin to work on alignment is ensuring that everyone is familiar with the principles that have been developed by SPORE, the Strategy for Patient-Oriented Research, which comes from CIHR. And SPORE is the implementation arm for the patient engagement activities there. This is part of the SPORE patient engagement framework, and principles, in my view, if embraced by all, create a pool of shared meaning. This is a term that's used in organizational behavior workshops, particularly one called Crucial Conversations. And all it really means is we all come to the table with our own meanings. And if we are successful in bringing those thoughts together and coming away with a shared understanding, then we are well positioned to move forward in terms of patient partnership. And those principles include inclusivity, where there is perspectives brought to the table from many groups, including minority groups, marginalized groups, and so on. Providing support to facilitate patient partnership in terms of flexible environments and training opportunities that will meet patients' diverse needs. In other words, patients, when they become patient partners, require training and orientation to the ever fascinating world of research. Prompting mutual respect in terms of valuing patients, researchers, and clinicians' perspectives through regular discussions. This is challenging. Everyone is very busy, but this really speaks to the need for everyone to listen to the views of others and to attempt to understand the perspectives that come to the table. And lastly, co-building research projects by identifying priorities and gaps and working together to implement solutions. All of this to say that the research team is really a team that includes not only scientists, clinicians, it includes patients as well. Okay, this is busy, but I'll take this through you quickly. In looking at the continuum of engagement practices, you can see that input can range, or engagement can encompass input, consultation, and collaboration. This is an interesting study that was a review of 126 peer-reviewed journal articles. And what was found is, as you can see here, in terms of patient engagement, 46% of engagement opportunities within those articles spoke to consultation with or without input, whereas 37% involved collaboration or shared leadership with or without other practices. So let's look a bit at what are those defining characteristics of the patient role. In input, patients provide information, information flows unidirectionally, and patients have no decision-making ability. And I have to say, I'm happy to see that that's on the low end in terms of representation of patient engagement. Consultation focuses on support or advice on specific attributes. Information flows both uni and bidirectionally, and decision-making is limited to specific activities within the research program. Collaboration, which is for many patient partners the gold standard, represents active participation in agenda setting and decision-making. Information flows bidirectionally, and decision-making responsibility is shared. Now, I have provided examples for each of those types of engagement, and what I want to point out is that the tick marks that you see represent all of the activities that I have been involved with in my almost 3 years of participation at OICR. And I say this to illustrate that there are many, many opportunities. Moving on, I did want to highlight again where patient partners are most likely to be found within projects in terms of engagement, what their contributions are, and the effect of those contributions. Interventions represents the most common area where patient partners contribute to the project. And typically that includes adaptation of intervention elements, including delivery, tools, materials, et cetera, et cetera. And the effect of that is better alignment with patients' culture and preferences. Secondly, the research focus. And you can see that it's in the number 2 slot in terms of types of involvement in project phases. This focuses primarily on the determination of outcomes, and the research focus that is meaningful for patients then has an opportunity to be contributed to the thinking around the project. Data collection and measures in terms of reordering, shortening, and adding items when data is being identified and methods of measurement are being considered. And that definitely has enhanced participant experience. Lastly, recruitment and enrollment. This involves optimal strategies to find and recruit for specific populations or settings, and results in a strong and enhanced enrollment practice. This work came out of PCORI, the Patient-Centered Outcomes Research Institute, and was published in 2019. So I suspect that you'll see a bit of a difference in the numbers if this study was to be repeated now. But I think it's a good indication of where and how patients are making a difference in research. Moving on from there, I think we have to look at raising the bar on patient engagement. And I'm drawing this information from a commentary that was published recently in 2023, entitled Reflections on Patient Engagement by Patient Partners. How can it go wrong? And I think that this is important to take a look at only because we have come a long way in terms of patient engagement, and we still have a long way to go. And so it's important to stop and take a look at not only what's going well, but also what's not going well, where could we see some improvements. And Don Richards and 5 other patient partners came together and in a focus group format, they talked about when does engagement go wrong. And the 4 areas that they highlighted are when patient partners are a check mark. And we all know what this means. It's what we like to call tokenism, where although participation is invited, it may not be wanted or listened to. And there may be no acknowledgement of insights, contributions, or ideas. So there is the question that perhaps researchers on the team need to ask is, how do we accept feedback from patient partners and integrate it into our work? Secondly, unconscious bias towards patient partners, where lived experiences are not seen as true experience and are given less credence and respect. Although it may be unintentional, it speaks to the power imbalance that can often exist in research teams that have patient partners. The question to ask is, how can we ask more thoughtful questions of patient partners about their lived experience? The third area where engagement can go wrong is lack of support to fully include patient partners. And this may be something as simple as supporting full participation by understanding how well patient partners can use technology. It may be appreciating how far away patient partners may be, and to ensure that in addition to having face-to-face meetings, there are always opportunities for simultaneous Zoom call. From a researcher standpoint, how can we create safer and more inclusive places for real and meaningful discussions? And lastly, lack of recognizing the vulnerability of patient partners. And this can be difficult to talk about and difficult to manage, but we're really talking about the failure to appreciate that patient partners often relive emotional or traumatic parts of their lives for the sake of the project. And that can be very stressful for the patient partner. So we need to ask, how can we share our power and privilege with patient partners to create a safe place, to recognize when patient partners require support and to provide that support to them. So in closing, I would just say that I think the experience that I and others have had at OICR are not out of line with what we see nationally or even internationally. And I think that this information, particularly Dawn's work around how do we really be honest about when engagement goes wrong, will really help us to move patient partnership forward even further. So thank you for your attention.
I'll let everyone get a few minutes behind, so maybe the upcoming speakers can just make it through their slides as quickly as they can. Although I know everyone has really excellent presentations coming up. Our next speaker, want to put up the slides?
Chloe, you can go ahead and share your slides.
Okay, thanks. Okay, so thanks everyone for the opportunity to present today.
Sorry, Chloe. I
okay.
thought you were going to put up a bio
Yeah,
slide.
sorry.
Oh, sorry, I thought that
No.
you had the bio.
No.
Sorry about that.
Sorry.
Yeah,
No, I
let
want to
me
make
put
sure
up
you have an
the-
introduction before you get started. Sorry about that.
Sorry about
Maybe
that.
I'll just pull it up. Now that she's here, I'll pull it up on my screen. But
Chloe, do you mind closing your slide so I can pull it up from here? 1 second. Sorry about that.
Sorry.
One second. All right.
okay. Now we can see your bio. Thanks so much. Start with the confusion there. So Chloe Mighton is a PhD candidate in the Genomics Health Services Research Program at Unity Health Toronto and the University of Toronto, supervised by Dr. Yvonne Bombard. Her research is focused on the clinical application of genomic technologies with specific interests in secondary findings and variants of uncertain significance. Over to you, Chloe. Thank you.
Thank you. Okay, sorry, I'll just share my screen now. Thanks so much for the introduction, and thank you for the opportunity to speak here today. And I'll be sharing some of our findings, some of our research related to exploring the patient voice in the context of genomic sequencing. Sorry, just having some technical difficulties here. The slides. Sorry.
Okay. Yeah,
Sorry
it's
about
working now.
Thank you. All right, there we go. All right, so genomic sequencing, which refers to both exome sequencing and genome sequencing, is a comprehensive class of genetic test in which an individual's genetic code is sequenced and analyzed very broadly in order to identify pathogenic disease-causing variants. And genomic sequencing is increasingly used in cancer care. So this can either be in the context of paired tumor normal sequencing, in which somatic tumor DNA and germline DNA are sequenced and then compared in order to identify potentially actionable variants in the tumor that can guide targeted treatments. And genomic sequencing can also be used in the context of diagnostic testing for hereditary cancer syndromes, where patients' germline DNA is sequenced to identify whether their cancer has an underlying heritable genetic basis, such as a BRCA1 or a BRCA2 variant, which can cause hereditary breast and ovarian cancer syndrome. And these results have implications for patients' clinical management, such as risk reduction, as well as cascade testing to identify at-risk relatives. A challenge with genomic sequencing is that because the test looks so broadly at a person's genome, it can also identify many other genetic variants that are unrelated to the diagnostic indication for cancer, for testing, in this case, unrelated to cancer. But these variants might still be clinically significant, and these are called secondary findings. So there are a wide range of results that can be analyzed and returned to patients. These include medically actionable findings. These are variants associated with risks for diseases that have preventive interventions or treatments. The genomic sequencing can also identify risks for non-actionable diseases, a subset of which are early onset neurodegenerative conditions. Another type of result that can be identified is carrier status, which has implications for reproductive planning. And another type of result is pharmacogenomic variants that have implications for drug dosing. And these secondary findings have really been the focus of a lot of debate and controversy internationally, and professional organizations have ultimately come to different positions on these results. So the American College of Medical Genetics and Genomics, or the ACMG, has released a very influential statements recommending that a minimum set of medically actionable secondary findings be analyzed and returned to patients when they're having genomic sequencing. But in contrast, Canadian and European policies are more conservative, and they recommend limiting the identification of secondary findings, citing a lack of evidence on the outcomes of disclosing these results. But they do say that medically actionable findings can be disclosed if they're identified. So all of these guidelines really prioritize medical actions and medically actionable results. But is this aligned with what patients actually want? So from the literature, it's clear that patients, research participants, and members of the public actually are interested in learning most types of genomic results, including non-medically actionable results and carrier status, as well as other types of findings. And so we were really interested in understanding why this was and what factors are sort of driving these preferences for wanting to learn secondary findings. So we conducted qualitative interviews with adult patients who have a strong family history of cancer or a personal history of cancer, but who had had uninformative genetic testing to explore their preferences for hypothetically learning a broad range of secondary findings, including non-medically actionable results. And from these interviews and understanding these patient perspectives, we found that preserving quality of life was an overarching motivator, both for wanting to learn secondary findings and not wanting to learn secondary findings. So some participants preferred not to learn specific types of secondary findings because, in their words, these results could ruin your quality of life, such as by causing negative psychological impacts. In particular, these concerns were around results that were not actionable, and especially those associated with neurodegenerative conditions. And these participants tended to prioritize medically actionable results and preferred not to learn other categories. In contrast, many participants actually perceived that learning secondary findings would help them to have a good quality of life, such as through informing actions to maintain their physical health or leading to psychological benefits, such as emotional preparation for disease. And this motivated them to want to learn many types of secondary findings. And the value that participants saw in these secondary findings and the actions that they anticipated being able to take based on these secondary findings really went beyond the traditional paradigm of medical actionability and clinical utility and encompassed things like helping them to change their life outcome, contributing to planning for the future, and informing lifestyle changes that might help to reduce disease risk. And all of these things were seen as being able to contribute to their quality of life. So in the words of one of the participants, "I've got to know everything. And if it can't be treated well, so be it. But what other steps can I take to have a good quality of life?" We also found that patients really approached the decision about learning secondary findings in different ways and from a variety of viewpoints. And we found 5 patient personas that reflected shared attitudes, concerns, perceived utility, and contextual factors. So information enthusiasts really self-identified as being planners and valued learning most or all types of secondary findings in order to enable them to help plan for the future or take action to prevent disease, because they, in their words, said knowledge is power. In contrast, concerned individuals define themselves as being anxious and were typically very reluctant to learn secondary findings, anticipating potential negative psychological impacts and really focusing on the limitations of the technology and the uncertainty of these disease risks. And these participants tended to select few or no categories. Contemplators were discerning about the potential value as well as the limitation of secondary findings and engaged in a lot of deliberation where they weighed the potential health benefits, such as being able to inform disease prevention, with the impact of not being able to unknow information that could potentially be distressing. Individuals of advanced life stage did not consider secondary findings to be particularly relevant for themselves based on their stage in life, but primarily considered the implications of these results for their family members, and saw the value of being able to share these results with their children, as well as to help their children plan for the future and to potentially alleviate burdens from their children. And then finally, reassurance seekers had been reassured by their previous negative genetic test results and shaped their expectations that they would not receive any secondary findings, which could reassure them about their disease risks. And this possibly reflected some misunderstandings about secondary findings. So sort of listening to the patient voice really allowed us here to understand factors that drove patients' decisions about learning secondary findings, and how they sort of approached these decisions about learning this genetic information. And these findings really highlighted that patients want to learn more types of secondary findings than what guidelines recommend, and they really see utility or value in these results that goes beyond traditional medical actions. And also, these findings also highlighted that it's important to give patients a choice about what type of secondary findings to learn, given this variability in their perspectives about learning different types of results, and that it's important to offer preference-sensitive and tailored genetic counseling to individuals who are considering learning these results. So these were conducted in a hypothetical context, but what happens when you actually operationalize this? So we conducted a randomized controlled trial to assess the outcomes of returning all types of clinically relevant secondary findings from genomic sequencing. So adult cancer patients who had a family history and personal history of cancer that was suggestive of a hereditary cancer syndrome, but for whom standard of care testing was negative, were recruited from familial cancer clinics in Toronto. And they were randomized in the trial. So both arms had genomic sequencing with primary cancer findings returned to them if those were identified. And then the intervention arm also had the choice of learning secondary findings. So patients had pre-test counseling in order to decide what types of secondary findings they wanted to learn across different categories. So medically actionable, non-actionable Mendelian findings, carrier status, pharmacogenomic variants, for example. And then when patients' sequencing results were being analyzed, only the categories that they had elected to learn were actually looked at, and all others were masked bioinformatically. And then variants were interpreted according to current standards, and pathogenic or likely pathogenic variants were reported as secondary findings. The study genetic counselors returned results to participants, and then patients were referred for follow-up as needed. And patient-reported outcome measures were then assessed at multiple time points after the return of results, up to 1 year following return of results. And the primary outcome for the trial was distress, and secondary outcomes included clinical utility and health behavior changes. So we found a very high uptake of secondary findings, with over 80% of participants choosing to learn each category of results. 99% chose medically actionable results. The category that was selected the least was early onset neurodegenerative conditions, with only 81% of participants selecting that category. And 76% of participants chose to learn all categories of secondary findings. And since we had analyzed so broadly, our yield of secondary findings was also very high. So all participants who had elected to learn secondary findings had at least one result reported. So 15% of participants had medically actionable findings. A smaller subset, only about 1%, had results in those ACMG recommended genes. Almost 30% had results related to non-actionable Mendelian disorders. And about 2% had results related to early onset neurodegenerative conditions. And it's important to remember that these are all disease risks. These were not diagnostic findings, but these just indicate a risk or a predisposition. And then most participants had carrier status findings, pharmacogenomic variants, and common disease risk variants reported. And importantly, secondary findings demonstrated clinical utility by informing changes in patients' medical management. So about 22% of participants had a change in their management because of their secondary findings. Many of these were specialist appointments, which had been recommended by the study clinicians, but there were also a number of patient-initiated actions, such as family doctor appointments and changes in their medications. And interestingly, secondary findings across all categories of results triggered changes in patient management, not just those that had a priori been categorized as being medically actionable. And with regards to the trial primary outcomes, we did not find that returning secondary findings increased distress relative to primary findings, suggesting that returning these results in this cancer population is psychologically safe. And moreover, secondary findings were effective at promoting risk-reducing medical and lifestyle behavior changes, including healthcare provider visits, changes to physical activity, and diet. And again, these behavior changes were initiated based on secondary findings across all categories, not just medically actionable findings, reinforcing what we had learned from the qualitative work, that patients really find actionability in all of these types of results. So in conclusion, cancer patients value having a choice about learning secondary findings from genomic sequencing, and they wish to learn a broad range of results beyond those that are currently endorsed by guidelines. And we found evidence that returning a broad range of secondary findings among adult cancer patients did have clinical utility, was psychologically safe, and was effective for informing health behavior changes. So these findings provide evidence in support of returning secondary findings among adult cancer patients or research participants who are undergoing genomic sequencing, which is aligned with patient preferences. So I'd like to acknowledge my supervisor and all the members of the Bombard Lab and our study team. And thank you all for the opportunity to speak here.
Thank you, Chloe. That was incredible. Really interesting results there. Really interesting process, which I'm really looking forward to getting into in the question and answer.
Thank you.
Now I'll turn, you're welcome. Now I'll turn over to Jay Romnoth, who joined the OICR Drug Discovery Program in August 2019 and is currently an associate director in the program. Prior to OICR, Jay was a medicinal chemistry consultant for Talon Pharmaceuticals and Triphase Accelerator. He has over 20 years experience in drug discovery and preclinical drug development, working on oncology, antibacterial, and CNS therapeutics. And Carol Gordon, it's also my privilege to introduce Carol Gordon, who's on our OICR PFAC. Carol is a late-stage gynae cancer survivor with a career in finance. She has been a patient partner for 8 years with the Canadian Cancer Clinical Trials Group and is currently on the gynae executive committee there, as well as on OICR's PFAC, where we're very proud to have her. Carol has been a patient partner in OICR's clinical translation program for 3 years, and more recently become involved in therapeutic innovation. Over to you, Jay and Carol.
Thanks very much. Thanks very much, Justin and Shola. Can you all see my slides?
We can see your slides. We also see your notes. I think you're in.
Okay. Yeah. So let me try that again. Sorry about that.
No.
Can you see? It looks like I have to restart the presentation. Sorry.
Oh, I can share your slides if you prefer.
No, I have it, Joel. It's just that I have the dual monitor and it's messing things up. Okay, so I'll share it again. Is that better? I'm gonna put it in presentation mode now. Is that good?
Yes.
Okay, perfect. Yeah. So
I'm not seeing any slides. I'm not sure.
No, I can't see any slides. It's not showing anything.
No slides yet, Jay.
can you see? For some reason, it said that Zoom quit for some reason, which is unfortunate.
You're still here.
Yeah. Okay. Sorry about that.
No worries.
Yeah.
If you have it open on your desktop, Shola can share and you can see your notes that way.
Can you see it?
Yeah, now
I don't have any notes. I'm just gonna present.
Okay.
I'll go briefly, quickly. Thanks for the opportunity to present at this the OICR Mondays, and I'll give you a quick brief introduction on therapeutic innovation. So as you know, therapeutic innovation is one of the 3 OICR research teams, and we're focused on drug discovery. So there are 2 main programs in TI, and they're called it's drug discovery program, and then there's a drug discovery funding program called Cancer Therapeutics Innovation Pipeline. And what I've done is I've put in the schematic below, I've shown you the drug discovery and development process, and just to show you, orient you where our programs are. To the left of that scheme are the basic researchers, the academic research, and to the right are is an approved therapeutic for cancer patients. So think of it that way. So where do we start? So we start at a novel validated cancer drug target, and by validated I mean that the biological target is associated with disease. There's some evidence to show that the biological target is associated with disease in some way, the cancer in this case. So once we have some evidence, we can start a drug discovery campaign. Essentially, what we're trying to do, we're trying to move along this pathway here. And we don't take it all the way to the end. We hand it off to someone else. So that's what to hand it off, it has to be attractive to that potential partner. Is that it has to have features that the partner is interested in, because it's a big investment usually that's required to take it along the pathway to ultimately to get it to patients. So we ensure that the drug product has a competitive target product profile. And I'll tell you what a target product profile is. It's all the features. It could be qualitative and quantitative that we look for in a molecule that could treat the cancer. And so essentially, so we move it along, and we find a partner. And fortunately, I have my older slides, but we're fortunate to have, as you can see, we're very in the early stage, and it's very technical, deep biology, heavy chemistry, and it's the language that we speak. Usually, patient partner, if you don't have a science background, you probably wouldn't understand us, or the general public may not understand us. So we're very fortunate to have Carol Gordon. She's agreed to help us out to be a patient partner to help our program. And one of the key things that Carol will work on, we see it as an opportunity where Carol can help us, especially with the target product profile. Like a scientist, you can have a long list of features and a molecule that you want. But as a patient, what are you looking for exactly? So we want to hear Carol's voice and help us define that product profile. What are the patients looking for? Because at the end of the day, the drug we're developing is for the patients. The other thing that we're looking for from Carol is for her to help us, to be an advocate for us, a champion for our projects. We're scientists. You can see all these things that we're doing. It's heavily laboratory focused. How can she help us? Like, how can she communicate to the general public, not only the general public, but also if you look at the downstream point, the physicians, the clinicians that are involved, how can she champion our projects and communicate to the clinician that we have the latest greatest thing that's coming along, and to get the clinicians excited and involved in our projects. So we again, I thank Carol. And in the interest of time, I had some slides on the drug discovery program, but I'm not going to go through that. I'll go straight to Carol's slide. And I think I have, I don't have Carol's slide in this presentation, but I'll pull it up now. I'm sorry. Yeah, so.
Okay.
Yeah, can you see my slide?
Yeah, no, we can see it.
Okay, I'll put in presentation mode. I'll turn it over to you, Carol.
Carol, you're muted.
Oh, thank you so much for pointing that out. It's a pleasure to be here today. I just wanted to review some of the things that cancer patients like me think of when we think of new drugs, and there's a variety of them, such as the ones shown here. And of course, scientists must address all these things and many, many more in their research. And it's incredible for me to think of how challenging the drug development field is. I also note that in the early stages of drug development, such as the therapeutic innovation stage, the 3 items listed here that I hear about most often from researchers are the drug efficacy, the toxicity, and the need for rigorous testing. At this stage, I hear less often about the longer-term quality of life impacts, the treatment burden, how quickly the cancer is likely to recur following treatment, and cost. Some of these items are studied later in the cancer drug development life cycle. Next slide, please. So the lower part of this slide is a rough depiction of the life cycle. Can you advance one more, please? Oh, I guess keep going to fill in the boxes. Sorry, I didn't realize this was this time. Okay, thank you. The boxes at the top are meant to describe how most often cancer patient partners are involved during this life cycle. So for most research, our involvement occurs at the beginning and end of the life cycle, with minimal patient partner interaction in the early validation through to the lead generation stage. And I base this on a review of literature and also my own experience with some cancer research organizations. The biggest area of patient engagement is at the end, it's at the clinical trial stage. I've spent 8 years providing input to the selection and design of clinical trials at these various organizations. But there is also some input at the beginning of the life cycle on the far left, and that's usually just advocacy work or completion of surveys. And this type of input is gathered by organizations such as the Canadian Cancer Society and other advocacy groups. So in my view, engaging as a patient partner in OICR's therapeutic innovation is novel, and I see it as a big step forward. However, there are some challenges in trying to provide input at these stages of drug development. Next slide, please. One challenge is that many patient concerns can't be determined at the therapeutic innovation stage. For example, whether a drug will affect a person's long-term quality of life may not be determined until the later years of a lengthy clinical trial. Another challenge is that the meetings to review drug proposals are by necessity as Jay said, highly technical and hard to follow by someone who doesn't have an advanced degree in biology or chemistry, which I do not. However, in my short-term learning about the program, I've gained some appreciation for how intriguing the therapeutic innovation stages are and just how much work is involved. I also appreciate the opportunity to express any concerns or needs up front. And this engagement, I think, also helps to fulfill OICR's strategic commitment to its funders. Next slide, please. So my involvement in CTEP began in June 2022. Since then, I've reviewed all the letter of intent submissions, the full submissions, and the progress updates that have been submitted. I've also attended TPAC meetings as a guest, and I've commented on lay summaries and whether I have any significant concerns with the proposals or updates. My involvement in drug discovery began 4 months ago. I've observed at scientific advisory committee meetings and a progress update for the HPK1 project. And in addition, as Jay said, the target product profile template was shared with me. And when I learn more, I hope to provide input to that target product profile. Going forward, I also hope to find ways to add some value in this amazing program. Thank you very much.
Thank you, Carol and Jay, and I can attest the fact that Carol adds a lot of value to all the projects she's part of, and she's part of many, many projects. Thank you. So now I'll introduce Glenn and John. Dr. Glenn Bauman is a radiation oncologist specializing in genitourinary and central nervous system malignancies. He is also the professor and past chair chief of the Department of Oncology at the University of Western Ontario. Dr. Bauman is an OICR researcher and clinical lead in the CT clinical translation program. Dr. Bauman's primary areas of clinical practice are in genitourinary and central nervous system tumors, and areas of research interest are multimodality, image-guided radiotherapy, and cancer imaging. And John Cunningham was born in Sydney, Australia. He arrived in Canada in 1962. He's happily married with 1 daughter and 1 granddaughter. John retired from a career in aviation and was a commercial airline pilot for over 30 years. In the last 10 years, he flew for Cathay, the Hong Kong airline. He contributes to the Climber trial as a patient partner. Welcome to Glenn and John.
John?
Okay. I will just, can you hear me okay?
Yes, we
Hear
can.
you loud and clear.
Okay, so just, and can you see my slides?
Yes.
We do.
Okay, all right. Well, thanks for the opportunity to participate in this session, and I'm going to speak a bit about the Argos Climber protocol, which I co-lead with Dr. Andrew Loblaw. Talk just very briefly about what the protocol is, and then John will I'll give my perspective on John's involvement with the project as a patient partner, and then he'll give his perspective as well. So this is a study looking at the use of advanced imaging in men with prostate cancer. Background of prostate cancer is it's a commonly diagnosed cancer, but fortunately, many of these cancers are indolent, would be low-risk cancers, and the ones that are higher risk, we have a number of treatments available so that ultimately most men who are diagnosed will not actually die of their prostate cancer. We have a variety of treatments available, and these tend to track with the extent of disease. So at the very earliest stages, when cancers are confined to the prostate and very typically associated with low blood PSA marker levels, some men may be eligible for observation with deferred treatment. Other men may be eligible for local treatments such as surgery or radiation or combinations. But as the burden of disease increases and the chance of cancer showing up in other parts of the body, then we start to rely less on the local therapies and more on systemic therapies like drug therapies. My specialty is within radiation oncology, and with OICR, we've had a long-standing research program looking at ways of integrating advanced imaging to improve our techniques for delivering radiation for men with prostate cancer. And one of the applications of imaging and radiation for prostate cancer is just through the better localization of the prostate for planning and delivery of radiation treatment. And you can see here, this is just a sample radiation plan, which is focused radiation on the prostate gland and protecting the rectum behind and the bladder in front. And then allowing us to monitor the location of the prostate while on treatment. So you can see in this split screen here, the initial CT scan used to plan the man and matched up with a scan of the day, showing that day to day there could be significant changes in anatomy. So here the rectum is much more full. Let's push the prostate forward. So by having this daily imaging, we can correct for those changes in anatomy. And this has allowed us to safely escalate the dose of radiation per day. And by doing so, reduce the number of treatments. So FX means fractions. So we're down now to schedules where we can give radiation in 5 treatments over 2 weeks instead of our traditional schedules of up to 8 weeks of treatment. And what we've seen is these shorter schedules have actually, in many cases, associated with better outcomes. So here, the short schedule is associated with a higher rate of biopsy clearance in this prospective study from Memorial Sloan Kettering Cancer Center. So this kind of paradigm works best if you have this ability to deliver targeted radiation married with technology that allows you to identify the cancer with high degree of precision. One of our challenges has been that our traditional imaging with bone scans and CAT scans has had limited sensitivity for finding prostate cancer in the prostate itself, as well as in lymph nodes and such. MRI has helped somewhat with the delineation of prostate cancer in the prostate itself, but is not as accurate outside of the prostate. But through a sort of a long history of collaboration with OICR and other partners, we've been able to pioneer the use of molecular imaging where we use a radioactive atom tagged to a specific molecule, which seeks out, in this case, a protein on prostate cancer cells called PSMA. And by using this combination of a probe, a radioactive probe, with a PET scanner, we can, with a high degree of accuracy, identify sites of cancer. So in this case, this is a side view of a man with prostate cancer. Here's uptake in the prostate. There's some normal excretion in the bladder here, some normal uptake in the liver here, but here we see lymph nodes in the abdomen. So these areas of cancer are highlighted by the tracer, and here is a combined PET MRI scan. So you can see the prostate gland here with lots of anatomic detail, and then the tracer is like a beacon showing exactly where in the prostate that cancer is located. Without this knowledge, we rely on sort of systematic biopsies throughout the prostate to help us understand the presence of cancer and where it is. But this gives us sort of a much more high degree of knowledge or precision in identifying the location of the cancer within the prostate. So this specific trial has 2 components: the Argos component, which is saying, can we use this sort of hypofractionated, this 5-fraction schedule to treat the whole prostate, but then give a higher dose to those areas in the prostate or in other lymph nodes in the pelvis to higher doses so that we can get better cancer control and reduce the risk of recurrence. And then the other component is saying, well, can we use this imaging to follow how successful our treatments have been by measuring whether the cancer is being cleared from the prostate, and does that clearance predict long-term disease control, so that if we know earlier on that the cancer is not being completely cleared from the prostate, maybe we have opportunities to intensify other components of the treatment, like drug treatment or hormone therapy. So anticipating the risk of recurrence and intervening earlier. So we have embarked on this prospective study, and we had John involved early on at the design phase, as John will talk about. He's been through radiation for prostate cancer, so had lived experience in this area, so provided valuable input into the design of the study. And this is just illustrating our first patient. So you can see a PET MRI here highlighting the presence of the prostate cancer. Here's the custom designed radiation plan, giving a higher dose to the center of the gland where the cancer is. And then this is the 6-month post-treatment plan showing that much less PET uptake within the prostate, showing an excellent response. And that was mirrored in a low PSA as well. So we have quite a number of individuals involved in this across many disciplines, including medical imaging, radiation oncology, imaging science, and we have John integral to the team as our patient partner. We operate. This project started when everything, during COVID, so everything was virtual. So we've had Zoom meetings throughout, and this has been a boon to us because our collaborators in Toronto and ourselves in London can get together on a monthly basis, and lowers the barrier to participation for everybody. So that's been great. So I guess just before I hand it over to John, I guess would note from my perspective, I've truly valued John's partnership with me in this protocol, and his personal experience with the prostate, this sort of stereotactic treatment. He has provided valuable insights and advice on the endpoints we're looking at, issues around consents and interventions that we were thinking about for the study, and how to design effective EDI components for the gland or for the grant. We successfully developed an extension protocol, and he was integral in helping develop that renewal or that extension funding. As I said, we've had good participation through our virtual meetings monthly, and John's been a good spokesperson for us in communicating out to the public about this through OICR media, and we've also been happy to have him as co-author on publications related to the project. So I'm going to turn it over to John now, and I can continue to advance the slides, John, if you want to just let me know when you want me to move on.
Okay, thanks, Glenn. Thanks very much for having me this afternoon. It's been very interesting. And I'd just like to give you a brief summary of my first experience as being a patient partner. I've always thought it's important for people, when possible, to take their ownership for their healthcare and to step into partnership with healthcare professionals, not simply as an advocate for themselves, but as a partner in their care. After my diagnosis, I gathered as much information and insight as I possibly could about prostate cancer, treatment options, and outcome probabilities. While information requires explanation, and the internet can be a double-edged sword, the information I gained allowed me to be a solid partner in my own care. It was not happening to me, it was happening with me. I was fortunate to have Dr. Bauman as my radiation oncologist, as he was willing to partner. When the opportunity to engage as patient partner in the Argus Climate Project presented itself, I viewed myself as a good candidate for involvement. My own care experience was positive. I was informed, engaged, and eager to contribute to the improved treatment and patient experience. I was motivated. Upon reflection, I think patient partners require a level of positive motivation to volunteer their time, energy, and honest input to contribute to the specific treatment, process improvement, and overall system improvement. Next slide, please, Glenn. The most important takeaway from this slide is that from the beginning, care was taken to ensure I was a strong contributing partner on the project. Still in the beginning, I was nervous because I only knew Dr. Bauman. Initially, terminology and clinical process steps seemed like another language, but with support became very manageable. Dr. Bauman would often pause the meeting and give me the layman version of the discussion. This made me feel included and part of the team. Meeting technology through Teams was an adventure. While meeting in person would have added a different dimension, the virtual format allowed me to easily engage as the whole team was on the call or on the screen. No expenses associated with my involvement, as it was just my time. Most importantly, from the beginning, I wanted to ensure my time and effort would be meaningful for the project, and my contribution would matter and help improve treatment being studied. At the time of each project, I tried to not only consider input through my own lens, but also remember the men in the study share a common diagnosis, but are all unique individuals. It was important to think beyond my own reality where possible. I was standing for the lived experience of other men as well. With that in mind, I tried to offer encouragement for the team to meaningfully incorporate good patient communication and continue checking for understanding all along the patient journey. Next slide, please, Glenn. I gained insight into how labor-intensive launching a new treatment protocol can be, and witnessed the value of those delivering care, pausing to engage someone with lived experience in the treatment design. I also observed the additional time and commitment required from the team to incorporate the patient voice and perspective, and appreciated everyone's patience with me. It would have been a much different experience for everyone involved, and most particularly me, if the effort had not been authentic. Dr. Baumann was particularly patient and open to questions and taking time to clarify. Every patient is unique. What is routine or standard standard for care providers is neither routine or standard for someone who is dealing with difficult, frightening diagnosis, treatment schedule, and effects of treatment. Real positive change in how healthcare is delivered depends on projects like this. Every member of the care team can make positive difference in the patient experience. Pausing to gain understanding, listening to input from patients' point of view is so important, and I now realize it is important right from the beginning of the design of the treatment. I would welcome the opportunity to participate again. While I do not see myself as a professional patient partner, I am motivated to be part of improvement in care delivery. It is very important. Thank you.